Hello, everyone. Good evening. You're all welcome this evening. It's so amazing to see all of you. You're welcome to our health talk, menopause, signs and symptoms, question and answer, and menopause and relationship. So we're going to be exploring this topic this evening. So everyone on Zoom, you're all welcome. Those on YouTube, you're all welcome. And I think as women, as family, it's important that we can come together and we can explore this topic. Today, my name is Uche Ademewa. I'm one of your hosts for the program tonight. And our second host is Sister Gillian Derry Williams. Sister Jill, can you say hello to people?
Hi, everyone. Hello.
Hello, Sister Jill. Hello. So, Sister Gillian, who is a co-host with me today, is an educational consultant. She's got a background in teaching and she's got an MA in special and inclusive education. And also, she's a specialist in autism. She's got an MA in autism. So, Sister Jill, welcome and thank you for being one of our hosts this evening. And I have the pleasure of introducing our speaker tonight, dear Dr. Pearl. I'm going to bring Dr. Pearl in and introduce her to us. Okay, just 1 minute, everyone. Okay, so this is Dr. Pearl. Dr. Pearl is a clinical lead. She's a GP, like we all have a GP. So we are quite very blessed to have her tonight. She's a GP, she's a clinical lead, and she's also a public speaker. She's actually a GP SI, that is a GP with special interest in menopause. And she has a specialist, one of her areas is specialist and a special interest in women's health, especially menopause, like I've said, diabetes and hypertension. Dr. Pearl has got so many degrees behind her name, so they are like up to 5, 6. So if I start to mention them, that is quite a lot. But I will give her opportunity to say a bit more about herself before she speaks to us. So Dr. Pearl, say hello and good evening. Welcome.
Hello, good evening, everybody. It's a pleasure to be here, and thank you so much for inviting me to talk about this really important topic. I think all of us are either, perimenopausal, menopausal, or we will get there. So this is really an area of health care and women's health in particular that's very dear to my heart. And I think it will impact every single woman alive. So it's an area that I really have a lot of interest in. Like our host has kindly said, I am a GP. I've worked for almost 20 plus years in the NHS. And I have, I've done a fair few things over my time, including diabetes, women's health, men's health, mental health, drug and addiction. But right now, my current interest is very much around the menopause and its ramifications for women and our long-term health, and in particular for women of color. So very much an area close to my heart. So thank you for having me.
Thank you, Dr. Pearl. So before we continue, this is Prayer Corner for Workers, and we know this is a place where God answers prayer. And we meet every morning, 5:30 a.m. UK time, to pray together, especially around areas of our work, our families, and our children. Before we proceed, we're going to have a short prayer by Sister Jill Derry Williams.
Let's pray. Our great God in heaven, we want to thank you that you have been here with us tonight. And Lord, we want to thank you that you are in our midst. And we want to thank you because you have brought 3 great minds together. Dear Lord, the minds are there to not only support ourselves, but to support the women who are tuned in this program. And Lord, we hope and pray that they would leave with their questions answered, and they would have a greater understanding of the menopausal process in their lives and in the lives of their families. So, dear God, we ask that your spirit remain with us and that, Lord, you keep us so that we will be able to continue this great work that you have given us to do tonight. May all heads that are bowed be blessed. In Jesus' name we have prayed. Amen.
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 So tonight we are going to ask Dr. Pearl to begin her presentation. And this is just part one of the presentation. We have another part that would be commencing sometime within this month or early November. However, tonight is dedicated to pre-menopausal and menopause sessions,
Symptoms.
and that we would all be able to ask questions at the end of the presentation. So whether you are on YouTube or if you are on Zoom, you will be able to probably write your questions in the chat or ask it verbally. So at this point in time, we want to give all our attention to Dr. Pearl, who will take us through her slides and her presentation.
Thank you so much. So I just want to confirm that, you can see that my slides, can you see the slides?
Yeah.
Yes.
Okay. All right. So I think we'll just dive in, dive straight in. And the talk is about menopause and the perimenopause. And I think it's very important that we use perimenopause, which is not just the time after the menopause, but also the time leading up to menopause. So I'm going to go, so what is the menopause and what is it? So the menopause is a medical term which is defined as 12 months after your last period. And the average age in the UK is 51. But for many of you women, it can happen before this. And it can either happen naturally because, that's what happens with time, or it can be induced by surgery, following or treatments. If a woman has had a hysterectomy or she's had some form of medical treatment, then she can have a medically induced menopause or perimenopause. And what is the perimenopause? And I think this is where a lot of women sort of do not have that level of knowledge or understanding about what's changing in their bodies. And the perimenopause is the time leading up to your menopause, when the periods begin to change. And you might women find that they may have one or two menopausal symptoms. And it's normally triggered by the hormones slowing down and your ovaries are producing less hormones. This usually occurs about 7 to 10 years before your menopause. So if you assume that your menopause will occur around 50, 51, you probably will be perimenopausal in your early 40s. And so it's very important that women are able to take note and understand that if they're noticing changes, then they can understand that these changes may be perimenopausal changes. And that these changes are as a result of hormonal changes. And women's bodies produce 3 types of hormones. They were normally called sex hormones, but we know now that they do impact every aspect of a woman's body. And there's a fall in estrogen, progesterone, and testosterone. And once those perimenopausal and menopausal changes occur, and the hormones drop, the hormones will stay low forever. So you never go, people say, I'm going to come out of the menopause, and you never do. You become menopausal, and that's where you do. That's what you stay, because you are in a state of low hormones, or hormone deficiency. So like I said, it can occur mainly in the early 40s. And every woman will have will become either perimenopausal or menopausal so long as she's alive, and she reaches that age, she gets into her 30s and 40s and over. And we know that 80% of women will have symptoms. So it's a very common symptom, or it's a very common presentation. And we know that studies have shown that 25% of women will have severe symptoms that have a negative impact on their ability to function. We know that 1 in 100 women will have what we call a premature ovarian insufficiency. And that is when women are aged under 40 and when the menses cease. We also know that the life expectancy for women in the UK is on the average 82, and there are a lot of women who will live much longer than that. So that will then tell you that about 30% of women, or 30% of a woman's life, will be in the postmenopausal stage or the post-reproductive period of her life. So it's a very significant time for women to consider how this is going to affect their health. And what are the symptoms of the menopause and the perimenopause? And we know that, as I've said earlier, 80 to 85% of women will experience symptoms of the perimenopause and the menopause. And this is so significant that it can affect both their home and working lives. And the severity of symptoms, that's how much it impacts them, can vary tremendously from one woman to another. Some women will experience symptoms for a few months, and for some women, it can carry on for decades, for many, many years. And so it's definitely a thing to be thinking of as a woman about how this is affecting you, or how it may affect you if you're in that perimenopausal stage. And so what are the symptoms of the menopause that you may expect? And I think a lot of women, are quite knowledgeable about, hot flushes and night sweats. And that's really what most women think about when they think about the menopause, and think, well, if I don't have hot flushes and I don't have night sweats, then I'm fine. But I have an infographic here that shows all of the symptoms, and, they are quite extensive. We can divide them into the physiological changes, muscle and joint pain changes in their menstrual cycle, vaginal symptoms, urinary symptoms, symptoms around their skin, breast. We know it can affect the heart. It can also cause headaches and systemic symptoms, for example, weight gain. So when we talk about the psychological symptoms, and a lot of women find out that they have more, that the changes in their psychological symptoms may be the first manifestation of the symptoms of the perimenopause and the menopause. And these may, some of these symptoms, may be things like dizziness, poor sleep, feeling very anxious, the poor memory or brain fog, inability to concentrate. Your brain is not as sharp as it has always been. They feel their moods are up and down. They can feel that their moods are becoming a bit depressed. They're irritable. They might feel quite angry. They may have mood swings. And of course, a lot of women have poor libido, which is loss of interest in sexual activity. A lot of women get back pain or joint pain or muscle soreness or stiffness. You find that your knees hurt a bit, your shoulders ache, your hands and fingers ache, your ankles are hurting, you lie down and you just have that sort of generalized body ache or overall body pain. We know that during the perimenopause, the menstruations begin to change. And so women might find that their symptoms are either longer or shorter. They may have some bleeding in between their periods. Or they may have very heavy periods, or some women will just have, just a complete shutdown. They expect their period, it doesn't come, and that's it. So every woman is different, and each woman needs to be looking at how these symptoms, affect her. Other symptoms include things like vaginal dryness. Some women have irritation and soreness, or they think they have a lot of urinary tract infections. And they have series of courses of antibiotics, and actually it's the effect of the menopause or the perimenopause on the vaginal area. They may find intercourses painful and dry and quite sore. They may have problems around passing urine. Either they have incontinence, that means that they can't hold their urine very well. They cough or sneeze and leak. They may feel the need to go all the time, or they feel that urge to go a lot more frequently. So a lot of women have hot flushes, which tend to be the most common symptom, itching, dryness, thinning of the hair. They might find that their skin is tingling. Some women describe what we call formication, the feeling of, either insects or ants, on their skin. They might notice that they have changes in their breasts or some breast pain, palpitations, headaches, and they find that, during the area, migraine might get worse, and headaches. So, these are, like I said, these are some of the more common symptoms, which I've described here, worsening migraines, urinary symptoms, hair changes. And, a lot of us think, well, my mother or our mothers have always, women before us have always gone through the menopause. Why is it important? And why is menopause and perimenopausal care important? So a study in the US has shown that women who have a non-surgical menopause or a menopause before the age of 40 had a 50% higher mortality rate than those who become menopausal at the age 50 or older. So, and when you say, what do I mean by a higher mortality rate? That means they are more likely to die if you've had an early menopause than if your menopause occurs at the natural age of around 50. And we know that women who had a non-surgical menopause between the ages of 40 and 50 had no increased mortality. And we know that a community-based study has shown that there's a 95% increase in the risk of dying from all causes when women have an early menopause. So if a woman has a natural menopause before the age of 40, and she's not put on hormones, so she doesn't have her, the natural progression of hormones for those extra 10 years, then her risk of dying from all causes, whether that's a heart attack, a stroke, diabetes, whatever, has been shown to increase. So it is important for women to be thinking about their hormones and their menopause and perimenopause, not just when they're menopausal, but in those years leading up to it. And if you're a woman who's experiencing, very early loss of periods, then it's definitely something you need to be speaking to your clinician about. I think I'm dinner with my, okay. And so what are the long-term risks of the menopause, and why is it important? So we've talked about a lot of the, a lot of the symptoms that women can experience. And we know that this happens because women have estrogen receptors in every tissue and every organ of a woman's body. So you have estrogen receptors in your breasts, in your bone, your brain, your liver, your colon, your skin, salivary glands, eyes, you name it, so long as there's a tissue, and even your hair. And that's why women find as they get older, their hair thins out, they lose their fullness, it changes color, that's when the grayness comes. And that's really because of the estrogen receptors and the lack of estrogen as they get older. Other long-term risks of the menopause include things like osteoporosis. And what is osteoporosis? So osteoporosis is it's a bone thinning disease whereby the bones become very brittle and very weak. And women are more like, and people who have it, men and women are at higher risk of, fractures or broken bones. And we know that 10%, women lose up to 10% of their bone strength in the first 5 years after menopause. So if you had a menopause at the age of 45, by the time you're 50, you've lost 10% of your bone strength. If you're 50, by the time you're 55, you've lost about 10% of your bone strength. So it's a very important, change that's going on in a woman's body. And people with osteoporosis have increased risk of fractures or breaks, even with little or no trauma. That means that normal stresses from either standing, coughing, hugging, a simple fall, you trip over, you put out your hand, or you fall down and you break your hip. And that's really because the bones are no longer weak and are fragile. And so, and with the risk of osteoporosis is also the risk of death. So the numbers are quite stark. We know that in the leading cause of death of women worldwide is ischemic heart disease, which is, having a heart attack followed by a stroke. And that's the leading cause of death for women across the world as they get older, not even breast cancer. And estrogen, we know, help to keep the blood vessels healthy, and it can help control cholesterol. And so that we know that the fluctuating levels of estrogen can increase the risk of getting cardiovascular disease, and therefore the risk of having a heart attack or having a stroke. Other factors, include high blood pressure. So if your blood pressure is not well monitored, or it's not well, it's not kept in check, or if you're overweight, or you smoke, or you have a family history of heart disease, that puts women at a much higher risk of cardiovascular disease, or the ischemic heart disease and a stroke, and therefore, that increases one's risk of death at an early age. So these are quite stark information about what happens as when we get older. When we're young, we really don't think about these things, and we just assume that if somebody gets to 60, or then all of these things, that's a natural progression. But we're learning now that it doesn't really have to be that way. That there are things that can be done, and women need to be, thinking about how they want to go into their older years. Another symptom that is quite common around the menopause and the perimenopause is vaginal dryness and urinary symptoms. And I'm sure, both for women listening, and if you happen to listen to this on YouTube, we all know women who, you cough and you sneeze and you leak a bit, or you have, when you're out on a journey, you have to make sure that you know where all of the toilets are. And we do have women who, who just won't go out because, they are so worried about, if they have a leak, or they're not able to hold their urine. We know that vaginal dryness, which is that feeling of soreness or dryness down in the vaginal area, and gets worse as women get older. We also know that intercourse can become painful, and for some women, just sitting and walking becomes a real problem. And some women are so badly affected. They are so sore in their vulval and vaginal areas that they, even having a smear is, they would not want to have smears because they feel so painful and sore during the perimenopause and the menopausal time. So it does affect women in all sorts of ways. In the UK, we know that dementia is the leading cause of death for women in the UK, even though we talked about heart disease and stroke being the leading cause of death worldwide. So this just shows a slight variation. And the American Heart Association has shown that women who experience a very early premenopause have a 35% higher risk of developing any kind of dementia in later life than those who entered menopause around the age of 50. So I think if you know someone, or you're somebody who's had a very early menopause, you need to be speaking to your doctor, your clinician, or your menopause specialist about what your options are. And we know women who entered menopause at the age of 45 or earlier were 1.3 times more likely to develop dementia before the age of 60, which is known as early onset dementia. So, the really stark figures. Because dementia is so prevalent, what the studies have also shown by Alzheimer's Society is that the number of women worldwide outnumber the men with dementia by 2 to 1. So there is definitely a female factor in this. And we are now beginning to show that estrogen can have a protective effect on brain cells. We know that estrogen supports brain function, and there's increasing evidence to suggest that HRT could play a role in reducing women's risk of dementia. One study showed that women who had taken HRT for 6 years or more were 79% less likely to develop Alzheimer's disease, and 77% less likely to develop any form of any neurodegenerative disease, including Parkinson's. So it doesn't matter whether it's MS, dementia, whether it's, Parkinson's, motor neuron disease. If women who are, had HRT were less likely to have any of these neurodegenerative diseases. So it's definitely, we know, so it's definitely, food for thought. So when we talk about menopause, we've talked so far about, what menopause is, why it's important, how it affects women, all of us, and what are the signs and symptoms that we need to be thinking about, and what stage in our lives should we be thinking about menopause. A lot of women think, well, it's it's only going to hit me when I'm 55 or in my middle or late 50s, but we know now that even in your early 40s, your late 30s, you should be thinking about your changing hormones if you're noticing any changes. So how do we manage the menopause? So there are definitely lifestyle changes that we need to do that we know have shown that would help. So keeping well, sleeping well, making sure that your bedroom is cool, you have a good sort of regularity, you have a level of how did I put it? So you have a plan every night. So everything is well timed. That's key. Managing low mood, anxiety, and stress. Like I said, eating well, making sure we eat right. We want to cut out things like smoking, excessive drinking alcohol. We want to get out. That's make time for regular exercise and leisure time. Check in, whether it's meditation, spiritual check-ins, being prayerful, all of those do help. Meet up, so make sure you have a good support network of friends and family that you can talk with, you can chat with, you can share both the good and the bad. Getting support, and whether that's from your friends and family, and if need be, if you're really struggling, professional support. And I think that's an area that a lot of people are very hesitant to explore, is professional support. But especially after COVID, we've seen a huge increase in mental health conditions. And so the ideal thing is, if you're struggling mentally, have the courage to seek help, because there is help available. Like we said, we need to prioritize time for leisure. And the studies have shown that 40% of adult women in the UK don't get enough exercise. And that's a lot of us. And so why is exercise important? Why is it important? So exercise improves our bone health. So, and we've talked about the risks, what we know about the risks of osteoporosis. So we know that it improves our bone health. And that's especially by doing all sorts of exercises. I always tell my patients, you don't need to go to the gym. You can be dancing in your front room. You could get a YouTube exercise program. You can go out for a walk. You can do dance, whether it's Zumba, whether it's traditional dance, whatever it is that you find enjoyable. Just think of something you can do to keep yourself moving. We know that it improves your muscle mass. And if you have good muscle strength and muscle mass, you're less likely to fall, because then your balance is good. And if you do fall, then you're less likely to break something, because you're strengthening your bones. We know it helps the heart. It helps improve heart contractility. That's the way the heart beats. It improves heart health. It reduces your risk of diabetes. It improves your mood. It reduces your risk of high blood pressure, and thereby the risk of a stroke. And it helps us keep a healthy weight. Another thing is eating well. And, we've all had diets that we've had over years, but what does it mean to eat well? So eating well is a balanced diet, and it has a multitude of benefits for menopause and future health. And that we know that the right foods can help combat fatigue. They help give your energy levels a boost. And we always talk about a Mediterranean diet. And I also think, what is a Mediterranean diet really? A Mediterranean diet is a diet that is essentially high in fish, high in fresh vegetables, particularly and olive oil. So most of yours come from traditional backgrounds. We're not saying you have to change your eating habits completely, but there are things that you can do to adopt a healthier eating pattern. We're looking for what we call low GI carb foods. So things like whole grain bread. So if you normally have a bread or a roll, you'd swap your white bread or your white roll for whole grain or brown, swap your white rice for brown rice. Make sure you're eating lots of pulses or legumes, or your dal, eating your beans, sweet potatoes, and lots of vegetables. They're always good for a healthy diet. We talked about, we also know that if you need to think about how much alcohol you drink, if you do drink alcohol. And the current guidance is to drink not more than 14 units in a week. But even within that, we are advising everybody to have alcohol-free days. So that's about a glass of wine or maximum 2 glasses of wine a night. But you definitely want to make that a small glass and have some alcohol-free days. Not smoking. I mean, there's no benefit to smoking ever. There just isn't. So, we wouldn't say cut down, just, if you can stop, that's the best thing. And if you need help with that, then speak to your GP, or your GP practice. There's so much help now around stop smoking support. We know that women who do smoke, it does increase the risk of heart disease, some cancers, and osteoporosis. And if you drink alcohol, we know that it worsens the severity of hot flushes or headaches, and it can negatively impact on your sleep quality. And then also it's looking at your work and relationships. Other important aspects of your diet would include making sure you have high calcium and vitamin D. And then you have to look at, what are high calcium foods? We could always do that as, so what are the foods that are going to support a healthy diet and a healthy perimenopause and menopausal period? So you want your calcium is your eggs, your fish, your legumes, your leafy green vegetables, high vitamin D, making sure you get out during the summer months, or you sit near a window if you're not able to get out, or vitamin D supplements. Especially over the winter months. And there is evidence to suggest that if you're darker skin tone, then you should ideally be taking vitamin D supplements through the winter months. And then come the summer, you can stop it. And the simple over-the-counter, anything between 800 to 1,000 units of vitamin D once a day is usually enough to keep your vitamin D levels up to a sufficient level. We know that eating gut-friendly foods and a diet high in fiber. So, when you look at your food, you want to have, you don't want to have a beige diet. You want to have a rich, I always call it a rainbow diet, lots of peppers and, leafy greens, spinach, all of those things that are very healthy, tomatoes, all of those things that give you put them on your plate and it looks nice and, nice and colorful, we know are very healthy. Your prebiotics and probiotic foods. So these are, for example, things like your garlic, your onions, your chicory, your ginger, your cabbage, your beetroot, your spices, your natural herbs are all very good. We want to think about your probiotic foods, which are things like, which contain live bacteria like your yeast. So these are things like your kefir, your live yogurt, your kombucha, sauerkraut, kimchi, your apple cider vinegar. And if I think about it, from a sort of an African Nigerian diet, you'll be thinking about things like, your ogili, all of those sorts of things, your pap, your ogidi, agidi, all of those things they are matured foods, and they do have live bacteria and yeast, which we know are very healthy for the gut. And then I'm always interested because I'm a doctor, and we look at not just what you can do in your lifestyle, which will always lay the foundation of how you keep healthy, but also what treatment options are available. And the hot topic now is hormone replacement therapy. So I'm just going to talk quickly about the basics. So we know that the most effective way to treat symptoms of the perimenopause and menopause is to replace the hormones that your body is no longer producing. And the guidelines from NICE, which is the National Institute of Clinical Excellence, which is the guidance book for all clinicians in the UK, is clear that the benefits of HRT outweigh the risks for the majority of women. So, it's a never say never. Don't ever say this is not for me. I'd always ask women to have a think, consider it. We know that taking HRT reduces your risk of osteoporosis, and even low doses provide bone protection. We know that HRT, or hormone replacement therapy, is the only known prevention treatment for osteoporosis. If you have osteoporosis, you can take things to treat it, but we know that just your HRT is the only known pharmacological prevention. Of course, your diet and your exercise will help, but if you already have thin bones, or you've had a fracture, or your vitamin D levels are low, then definitely I'd say consider where you'll stand with your HRT. And we know that taking HRT can reduce the risk of developing cardiovascular disease, and that's the risk of heart attacks and strokes. And so, what is HRT? So, we have what we call body identical HRT, and this contains estrogen, or the estradiol hormone, and it normally comes as a patch, a gel, or a spray. It doesn't have an increased risk of a clot or a stroke, and they are safe for women to take, even if they have had a high clot risk. If you have your womb, so you haven't had a hysterectomy for whatever reason, then you'll need to take a progesterone or a progestogen to protect the lining of the womb. And then another hormone is testosterone, which women produce, and it is not a male hormone; it's a female hormone. And we know that it is licensed in the UK for libido, but studies are showing now that it's also important for muscle strength, muscle mass, and memory, and maintains the memory. So this is just a quick pictogram of the different types of body identical hormonal treatments that are available. And if you happen to want to discuss it with your GP, always ask for body identical. You shouldn't be, body identical hormone, or speak to menopause specialist if you're unsure. So what are the benefits? And we know that of HRT, we know that if you take HRT, the Royal College of Obstetrics and Gynecology has shown that HRT has a 9% reduced risk of death from any cause. So it reduces your risk of mortality, your risk of dying from any cause by 9%. We know it reduces your risk of osteoporosis. And we know that women who take HRT are 79% less likely to develop Alzheimer's, and 77% less likely to develop any form of neurodegenerative disease. The current guidance is that women who have primary ovarian insufficiency and early menopause should be encouraged to use HRT at least until the average age of the menopause, which is about 50 or 51. So if you've had an early menopause for whatever reason, whether it's natural or surgical, you should have your hormones given back to you, replaced up until at least 51. We know that it reduces the risk of heart disease, and women who start HRT within 10 years of the menopause have a lower risk of heart disease. We know that if you start HRT after the age of after 10 years, you're likely to have a lower risk over time. We know that for hot flushes and night sweats, your HRT remains the most effective treatment currently available for the majority of women under the age of 60. And for if you have vaginal, symptoms, for example, very sore vagina and vulva, a lot of irritation, it is now called GSM, which is genitourinary symptoms of the menopause. And we know that this affects 80% of women. Vaginal estrogen is the only effective treatment, and it is safe even for women for whom, the very few women for whom systemic HRT is not appropriate. Another area is fibromyalgia, which is that, we know a lot of women who have sort of generalized body pain, fibromyalgia, muscle and joint pain, for which there isn't any particular reason, that there's no identifiable cause. And we find out that symptoms are more severe in postmenopausal women. And the current studies are suggesting that HRT may help, even if it might not cure it completely. So definitely, if you're suffering in any of these categories, definitely speak to your consultant or your menopause specialist. I'm just looking at the time, because I don't know whether you want me to carry on or whether we can, we should stop here for now.
So I think we need to give people, thank you so much, Doctor. Thank you. We need to give people some opportunities for questions, because this is the part 1, like was announced earlier. And then we're going to have another day when we come back and we can never finish the topic of menopause, as you know, it's your area and you're a specialist in this field. So we take some questions, if there are any questions. Otherwise, we can go into, do you want to maybe summarize a bit and then we go into questions? I don't want to leave it hanging.
All right, not a problem. So I'll just go to my last slide, because, we can always come back, but we can always come back, because menopause affects every aspect of a woman's life, and every aspect of a woman's body. And there, we can have discussions about it, for a long time, because as women get older, and they have all sorts of symptoms, there's definitely a need to have that discussion, not just what's happening to me, but what can I do? How will I know? Where do I go to get help? Where do I go to get information? I've probably spoken about it before. I've been told it's not, either I'm too young, I'm too old, what do I need to do to get help? So that we can definitely discuss that at another another time.
Date.
Yes. So when it comes to HRT, the bottom line is that, the benefits for starting HRT early, and you don't have to wait for your symptoms to become severe. Neither do you need to wait for your symptoms to stop before you start taking HRT. So you don't need to you don't need to be menopausal. If you're having perimenopausal symptoms, but you're still having periods and you're in that age bracket, or you're having symptoms, then definitely you can consider HRT. It is not a contraceptive, so you still need to think about making sure that your sexual health is good. Some women find that if they've had what we call premature ovarian insufficiency, or they have polycystic ovaries, sometimes when we put them on HRT, we find out that their fertility improves. There is no maximum length of time that you can take HRT. And HRT does not work by delaying the menopause. It doesn't. What it does is that it's replacing the hormones that your body's losing, and we know that you're going to live for about 30, 40 years in a non or an estrogen deficient state. And if you have menopausal symptoms after stopping HRT, then we know that these symptoms you'd have experienced would have carried on even if you hadn't taken HRT. So it doesn't, it's not like kicking the bucket down the line. You're keeping yourself healthy for longer. And then, yes, if you're still having symptoms, the important thing now is that you don't have to come off it if you don't want to. There's no upper limit in terms of the length of time for taking HRT. We know that HRT is beneficial for most women. And when I say most, I need probably about 90% of women should be able to consider HRT. It has many health benefits. And if you're really struggling in that perimenopausal time or that menopausal time, HRT can give you your life back. But also you want to be making sure you're healthy, you're keeping well, you're exercising, you're sleeping well, you're looking after your diet, you're looking after your spiritual and social health. And so it is a collective health and wellness time that women really need to be thinking about. You're managing your weight, cutting down alcohol, stopping smoking as you go into your, the post-reproductive phase of your life. So thank you so much. I hope that's been helpful.
Yes. Thank you. That has been very helpful. Maybe if we stop sharing the slides now, Doctor, thank you, so that we can see your face and we can take the questions. So I've got a question for you from one of the people on YouTube, and I just want to also welcome everyone, for those who joined us halfway, welcome to the program. You probably have covered this, but I'll give the question. It says, does HRT cause some form of cancer? Does it cause cancer?
So there is an infographic about HRT, and one of the really saddened things about the HRT was there was a particular study called the WHI, or the Women's Health Initiative, which was done in America. And this was about 25 years ago now. And it falsely claimed that HRT did cause cancer. Now, that study has been reevaluated time and over again, and it has found to be false. And they have actually refuted the fact that it causes cancer. There is a slight increased risk if you take HRT over the age, if you start HRT much later, but if you started early and definitely below the age of 60, then the risk of HRT is not higher than the risk of for example, being on the pill. It's not higher than I have actually had an infographic on my on my slide to demonstrate that. But if you're overweight, so if you have a BMI of 30, your risk of breast cancer is doubled. Whereas the risk of breast cancer following HRT is very minimal. But there has been a scare because there was a study that was done many years ago, and that falsely claimed that it did, but all of the authors have refuted that now. All of the evidence has been checked and rechecked and and really looked at with a fine-tooth comb. And it's been found that the risks are very minimal. So I hope that's answered that question.
Thank you very much. Thank you. Yeah.
Dr. Pearl, I've got a question here that was given to me before we started this program. It says, I thought I was in menopause because I haven't had a period in 3 years. But last month, I got my period again. I'm 50 years old. What could be happening?
So technically, the menopause is what we call a retrospective diagnosis. So if you haven't had a period for a year, for 12 months, then you are menopausal. That is the clinical diagnosis. Now, if you've not had a period for 3 years, and then you have what we call a bleed, what you have is what we call a postmenopausal bleed, which is not a period per se. So you need to be speaking to your doctor about that as a matter of urgency to have that checked. So whoever that is, make sure you book an appointment as soon as possible and get that checked. That is what we call postmenopausal bleed. And even though you are young, because you haven't had a period for 3 years, it does have a different categorization and will be treated differently. So please get that checked.
Thank you.
Okay, thank you very much for responding to that. Thank you. And there's another question that says, should Overstein, I hope that is pronounced correctly, Overstein, O-V-E-R-S-T-I-N-E, should Overstein be taken for life? That's a question, Doctor.
So Ovestin, I think that's what she's referring. Ovestin is a form of vaginal estrogen. And it is normally given for when I spoke earlier, what we call vaginal symptoms or genitourinary symptoms of the menopause. And, the vaginal symptoms And we know that up to 80% of women will have vaginal symptoms. And it is one symptom of the menopause where it can be soreness, irritation, pain, needing to pass urine lots of times, painful sex. You can't have a smear done. Your vaginal area just feels very itchy or very dry. It doesn't get better with time. It will not get better. So a lot of women might have been on several courses of antibiotics, or they've used things like canesten because they think they may have thrush because of the irritation for many courses, and they're still worried that they think there's something wrong. Actually, what they are is that they have what we call GSM. It used to be called atrophic vaginitis, or atrophic vulvulitis, but we now know that it is an estrogen deficiency symptom. So in terms of that, you will need your estrogen, your vaginal estrogen, and yes, you will need it for life.
Okay, thank you.
Yes.
Thank you, doctor. That was very informative. I've got another question here. It relates to pregnancy and perimenopausal or menopausal situations. Could one get pregnant while they're going through their perimenopausal state?
And the answer to that is you have to think about how your natural hormones, your natural physiological hormonal cycle. So as you go through the perimenopause, what your body is telling you is that your ovaries are no longer working as effectively or as efficiently as they would normally. It doesn't mean that you may not ovulate, but the likelihood is that you're not going to ovulate at every cycle. And therefore, you think your risk of getting pregnancy is lower, but it's not negative. And so we always advise women, to have, you should, if you're perimenopausal, that means you haven't yet had a period for a year, you should, or you're less than 55, then you should always think of contraception, because yes, you can get pregnant. And women who do go on HRT find that because, their bodies are used, they're now getting the natural type of hormones. And like I said, HRT is not a contraceptive. It does tend to improve the effectiveness of your own hormones. And yes, so women can get pregnant during that period. It is not, I'm not going to say that it is a treatment for infertility, because it's not, but but neither but it's not a contraception. So yes, you can get pregnant, but it's not a treatment for infertility.
Thank you. Thank
you very much. Okay, thank you. The last question from the audience is this: does menopause cause an increase in sense of smell? Doctor?
There are what we call, unexpected signs and symptoms of the menopause. And some women do tend to have, what we call less expected, unusual signs of the menopause. Some people find that their taste, their taste buds, their taste is off. Either they have a metallic taste, they might find that their smell changes. They may find that their eyes are very dry, that you have dry eyes. They may find that their skin is dry and itchy, so, they find that their hair is dry or their nails break, so these are not what we'd call common signs, but they are unusual, but they're not uncommon. And so, for this particular lady, if she's worried about the sense of smell, she needs to be, I think it's the kind of thing I would say, have a discussion with your GP, and make sure that you've had, you've had it, you've had yourself thoroughly checked, because a change in sense of smell may be perimenopausal, but that's not the only thing that could cause it. So, there are things from sinusitis, sinus infections, sinus polyps, a range of intranasal concerns that may cause a change in smell. And there are also more sinister things that might, causes of a change in smell. So I would definitely ask her to, if it's something that she's bothered about or has been going on for a little while, then definitely speak to her GP and get that checked.
Okay, thank you very much. Thank you on that. Yeah.
I know that Sister Uche said this is her last question, but I've got one question for me. I've never taken HRT and I am past 60. And what you are talking about now is that, oh my God, I think I do need to start to take this HRT. Am I too late?
So, and you know what, I because I do these talks, to different groups of women, at different times, The answer to that is, this is by what we call NICE. So NICE is the National Institute of Clinical Excellence. There is no upper limit to starting, and there is no upper limit to stopping. So you always have to, do what you call a risk-benefit analysis. And the current guidance is that the benefits outweigh the risks for the majority of women. So more women will get benefit than they will not. And that's for the majority of women. There will be a small few group for whom HRT is not appropriate, but for the majority, it will be fine. Like I said, nobody's too late. There is what we call a window of opportunity. Now, the window of opportunity is either before the age of 60 or within 10 years of your last period. So if you had your last period when you were 50 or 55, then your window of opportunity is up till you're 65. If you had if you had an early period, but you're below the age of 60, you're still within the window of opportunity. So that window of opportunity is really because that is when the risk of any form of heart disease is much lower. When you get older, you really then need to be thinking about managing your cardiovascular risk factors. So your heart factors, your blood pressure, your weight, your diabetes risk factors, your exercise, your eating, all of those become really important to manage going forward. But on the whole, you're never too late. I had a lady come to see me, oh God, that was yesterday, and she's 88 and she's still on HRT. And she said, "Doctor, I'm not coming off it." I said, "Well, I agree with you." She said, "Doctor, don't ever stop it." And I said, "Yeah, that's fine." And she's sprightly, she's active, she's really, really very fit for her age. And yeah, so absolutely, it's definitely a discussion you'd have with your GP. And I would ask every woman, if you're really considering HRT, don't get put off by the first, if you have the first negative consultation with your doctor. Not all doctors know enough about hormone therapy. And so, some of them are, really don't understand, the benefits and the risks, and may not be able to advise. So if you can't get it at the first point, ask for someone else, or go back and say, who in my practice, does menopause, because there may be one or two people who do that. And on the other hand, if you can't get it, or if you've had things like breast cancer, or you've had a clotting risk in the past, and you really think, I'm really struggling in my perimenopausal years, then you can be referred to a menopause specialist, and you should be able to ask for that. So if your GPs cannot help, then don't be afraid to say, well, if you don't know what to do, refer me to a menopause specialist. And not a gynecologist, it should be a menopause specialist.
Brilliant. Sister Pearl,
Okay.
we
Thank
just
you
want to
very
say
much.
thank you.
Yes, thank you.
Yeah. It has been a mind-blowing experience tonight. And I thought I knew everything about menopause, but I have to sit at the feet of the learned and just learn again, because it is so important to know how to keep our bodies fit and together and healthy in order to go through our menopausal stages. And you spoke about having a balanced diet, eating good food, eating well, sleeping well. All of these things have an effect on us, on our health, if we neglect them. Yes. And so we just have, as women, we have to listen and use. And I had a phobia about HRT, and I thought, oh no, I'm not going to take that. But it is very, very important that we do, because it replaces all the hormones that we have lost, as you have said, in our years. So Uche and I just want to thank you, because you have done so well for us tonight. And I'm sure every woman who have tuned in is now going away with some little nugget that they have learned new today. And we just want to give you our thanks and appreciation, and looking forward to part 2 when we will meet again to really go through this and to have a very healthy lifestyle at the end of it all. So thank you very much. Thank you.
Thank you,
Sister
Saju, for co-hosting
Uche,
with me. Thank you.
Oh, thank you so much. I really appreciate it. And and thank you for inviting me, and for being honored to share and to help and to support women, and to be just to be there to help answer questions. So because sometimes you just need to know where to go, or what do I listen to? You know, how do I get the information? And I'm just going to tell everybody, if whoever's going to listen to this, or if you're listening online, there is an app called the Balanced Menopause app, or you can go to a site called, it's called the Menopause Charity or the British Menopause Society, and there you will get validated information about almost everything that you want to, you want to know. So if you use the Balanced Menopause app, it's a free app which has been designed by a menopause specialist who is also a GP. And so she understands, there's a whole team of doctors, and you can use that and track your symptoms, ask questions, look for information, and arm yourself with knowledge, so that when you're speaking to your clinician, or whatever you're making a decision for yourself, you're coming from a position of knowledge, power, and understanding. Thank you.
Brilliant.
Thank you very much. Thank you everyone for attending. Thank you those on YouTube and those on Zoom. And I just want to remind you, I'm sure you have enjoyed this program. I've been looking at the comments, very informative. We just want to ask you to subscribe to our channel. We're going to have Dr. back again, and she's going to come with lots and lots of tips, lots of training for us. So subscribe to the channel so you're not waiting on us to send you the link. And why don't you share this to help other women? Once again, thank you so much for joining, and we will see you again shortly. Have a nice evening and good night. And then just to remind you, tomorrow we are meeting at 5:30 a.m. for our normal prayer before we start our day. Thank you everyone for coming, and bye from all of